My name is Dick Kauke from the NCSL Health Policy staff here at in the Denver office. Because this topic can be a bit complex, as you may see, we have several resources available, and some of those are printed. More useful, there are additional materials that are posted on the NCSL website and even in your NCSL app if you can make it work. And that includes full bios for the speakers and other extended handouts. A selected resource includes some of the technical material and more extensive reports, and it also includes a summary chart and even links to the text of all 7 major pieces of legislation, including the original ACA and the 6 bills that were under consideration. The lawyers among you may know that this is a CLE, or continuing legal education session, eligible for professional credits. So do sign the CLE form, and there are some handouts that may be specific to legal interests. None of our presenters today are using slides, but the half-dozen 50-state maps are available as a reference, and those are in your print files. My brief purpose right now is to simply introduce our moderators, who for some of you may need no real introduction. State Senator Deb Peters is widely known this week because she's President-elect of NCSL, and 24 hours from now will be President of NCSL. As well as she is a leader in the majority of the South Dakota legislature, where she served 6 years in the House and now her 7th year in the Senate. She's been recognized as one of the top 40 political rising stars, under 40 years old, by the Washington Post, and she chairs a couple committees in her legislature and also is president of the Streamlined Sales Tax Governing Board. Our other moderator, former Senator Richard Moore of Massachusetts, has had a storied career. He was president of NCSL in 2010, 2011, and has been on our executive committee for almost 20 years. Here at the Massachusetts State House, he was one of the principal architects of the landmark Massachusetts healthcare reform law that resulted in near universal health. He was founding co-chair of the state's healthcare financing committee until promoted to their Senate President pro tem, and he currently is president of the Massachusetts Assisted Living Association. With that, Senator Moore.
Thanks very much, Dick, and on behalf of my colleagues from Massachusetts, welcome again to Massachusetts, and I hope everybody's having a great time here and learning a lot, both in the sessions and maybe apart from the sessions, and seeing a little bit of the city and spending some money to close the deficit that we have in the state budget would be helpful. Let me just say that I suspect among the people here, certain perhaps among the speakers as well, healthcare is not a simple issue. The people have views all over the map, from total government management and resources, like a single payer. There are folks that believe in that. There are some where they think government should be somewhat responsible, overseeing consumer protection, perhaps encouraging help for those who might not be able to afford the prices of both health care and of health insurance, and provide some oversight. They have a more limited role, simply making sure that the basics are there, and some that think there should be basically no role of basically free market activity. So there's a range, and and that's probably oversimplifying the differences, because there's a lot of gray areas in between each of those types. Briefly, what Massachusetts did, we had a history of making adjustments and reforms of health care, whether children's health, elderly prescription assistance, things of that nature, that provided the basis for some interest in designing a program that got us to close to virtual coverage with people either insured or insured by private sector, or a combination of private and public, or all public in the process. We did it, interestingly, with a bipartisan development, both a Republican governor, Mitt Romney, a heavily majority Democrat in the legislature. We did it with a uniform vote in the Senate with 40 members voting all for the reforms. In the House, 158 of 160 voted for the reforms, including leadership. And in the Senate at the time, we had then State Senator, later United States Senator, and now Ambassador to New Zealand, Scott Brown, who voted for the reform. So it was something that we had worked closely with the minority party in both accepting amendments and working in the conference committee. Something that we probably, it seems that Governor Kasich recently wrote a piece in the Globe on Friday that suggests that maybe we've tried the all-Democrat, all-Republican versions, and maybe it will be time to start working on something that's a compromise of sorts in between. So we'll see what the current landscape is from our panelists, several panelists today, as to what might be coming down the line and what would be the role of the states. How involved should the states be? Do they want to be? And what issues that are facing you in your respective legislatures and states as we go forward. So I look forward, as I think you do, perhaps to the discussion from our keynote speaker and from all of our panelists during the course of the next couple of hours. Thanks.
All right. Good morning. It's like church. All right. So we're in the beginning of day 3. Most of you have already been at a couple of other meetings, so we're going to really kind of kick this off a little bit. But as you know, we've been in the middle of a discussion of health care at the national level. It is a has-been, maybe, maybe not. They're going to vote, they're not going to vote. They're going to repeal, they're not going to repeal. They're going to go lighter version, they're not. So trying to prepare for this particular session was a bit challenging because we really didn't know what the topic was going to be until a couple of days ago, based on what's going on in Washington, D.C. So, and as you all know, we're in an unpredictable time when it comes to the health care. We're also knowing that you guys, most of you in the room probably, have spent some considerable amount of time talking with a couple of experts on Sunday. So we heard from 2 federal experts, Seema Verma and Calder Lynch from the Centers of Medicare and Medicaid Services. And so, you know, those were some of the deep dives. Today we're trying to stay more on the higher level discussion. There's some folks that didn't have the deep dive, so we're hoping to be able to touch a variety of different topics today and get some information out. But today it's my privilege to introduce Jane Norton this morning as she's a seasoned state and federal policymaker. She's actually, you know, from my part of the world, Secretary Price. She's actually Secretary Price's Director of Intergovernmental and External Affairs, and she's charged with being the direct and two-way connection with state government. So she is basically our connection with Secretary Price's office. But just a quick overview of why she's one of us. She's an early Colorado state legislator. She's been the Colorado Lieutenant Governor with Governor Bill Owens, and she's a former HHS Region 8 Director, and she covered 6 states, Utah to South Dakota and North Dakota. So she's been there, she's been in the trenches, she's been working with us, and she knows what she's doing. So with that, I'm going to turn it over to Jane Norton.
I don't know if I'm seasoned or old, but thank you, Senator Peters, for that, and it's a pleasure to be with you. Senator Moore, thank you so much for this opportunity, and for all of you here. Let me just begin by saying how much I have admired the work of NCSL over the years, and I certainly respect the work that you as state legislators do. You are on the front lines of providing some of the solutions for some of our most intractable problems, and I appreciate that you do that. States are the laboratories of democracy and know best how to innovate and craft solutions to meet unique needs. So it's a privilege again to be here. Thank you for the opportunity. During my time with you today, I want to tell you a little bit about the department, about Secretary Price and his priorities, and then maybe suggest some ways that we can work together going forward. More importantly, I look forward to listening to your thoughts, your ideas, your challenges, your solutions about how we can make health care more affordable and accessible. Well, let me introduce, or in some cases reintroduce you to the U.S. Department of Health and Human Services, or HHS. Our mission at HHS is to enhance and protect the health and well-being of all Americans. We fulfill this mission through a staff of over 79,000 employees, over 300 programs, providing for effective health and human services, and fostering advances in medicine, public health, and social services. This year, our budget is set at just at $1.1 trillion. HHS has 11 operating divisions, including 8 agencies in the U.S. Public Health Services and 3 human services agencies. These divisions administer a wide variety of health and human services programs and conduct life-saving research for the nation, protecting and serving all Americans. In your electronic materials associated with this session this morning, you have an overview of HHS and the agencies that comprise HHS. I'm pleased to bring greetings from Secretary Tom Price. Dr. Price is a third-generation physician. He's the third physician to hold the post as Secretary of HHS. But maybe more interesting for this room is that he's also the 7th former state legislator to hold the post. His 4 terms in the Georgia State Senate, 12 years in Congress, and 20 years as a practicing physician have afforded him valuable experiences and insights to the work that we do to meet our mission. Well, certainly it's no surprise that healthcare reform has been our top priority, and supporting the President's vision to strengthen the insurance marketplace, put patients and doctors back in charge of healthcare decisions, and give states and local communities the resources and flexibility they need to meet the unique healthcare needs of their citizens. President Trump, Secretary Price, and the entire administration are as determined as ever to solve the healthcare challenges we have in this nation, because what's happening right now to Americans is unacceptable. Let me remind you, premiums have more than doubled under Obamacare, increasing on average by nearly $3,000, despite promises that premiums would decrease by $2,500. Thousands of Americans living in counties across the country right now may have no health care plan being offered on their Obamacare exchange for next year. In over 13 counties, or roughly 40% of the counties of our nation, folks may only have one coverage option on the exchanges next year, meaning they really have no choices. Over the past 2 years, the number of health issuers offering plans on Obamacare's exchanges has fallen by half. Millions of Americans are paying billions in IRS fines just for the right to go without health insurance. In 2015, 6.5 million Americans paid $3 billion just so they could go without Obamacare. The administration remains committed to improving our health care system so that it better serves the American people. Our goal is to foster a successful, patient-centered health care system where Americans have more choices and lower costs, where patients, families, and doctors are in charge of their medical decisions, and where Washington's interests take a backseat to patients' needs. The status quo is unacceptable, and it's not sustainable. In addition to health care reform, Dr. Price has laid out 3 clinical priorities for the department. I think this is an area where we can do much good bipartisan work together. Our first clinical priority is combating the opioid crisis. Today's opioid crisis is the deadliest drug epidemic in United States history, and it's getting worse. In 2015, 52,000 people died in overdoses in America, most of them to opioids. 2016 is estimated to be even worse, most likely exceeding 59,000 deaths, a 19% jump from the previous year. Drug overdose is now the leading cause of death in America among adults under 50 years of age. HHS is at the forefront of combating this crisis. In addition to representing HHS on President Trump's Presidential Commission on the Opioid Crisis, Secretary Price has laid out a 5-point strategy to address the epidemic, and I know the states can be great partners in this strategy. Our first strategy is improving access to treatment, including medication-assisted treatment and recovery services. To help the 90% of Americans who are struggling with addiction but are not getting treatment, HHS, through the 21st Century Cures Act, recently made available $485 million in grants to the states for evidence-based prevention and treatment activities. Our second strategy, promoting targeted availability and distribution of overdose reversing drugs. States have made great strides in expanding access to drugs like naloxone, which can reverse overdoses, saving thousands of lives each year. And at HHS, we are committed to making access to these lifesavers as easy and affordable as possible. Strategy number 3, strengthening our understanding of the epidemic through better public health data and reporting. HHS is committed to securing the very best possible information we can through programs like the CDC's Data-Driven Prevention Initiative and Enhanced State Opioid Overdose Surveillance Program that provide grants and technical assistance to state and local authorities to help track developments and respond in real time. Our fourth strategy, providing support for cutting-edge research on pain and addiction. Every day, HHS researchers at institutions like the National Institutes on Drug Abuse and scientists across the nation funded by HHS grants are exploring critical questions about addiction treatment, new and safer painkillers, and even addiction vaccines that will inform our efforts in years to come. And our fifth strategy, advancing better practices for pain management. In addition to promoting treatment and recovery, we have to avoid dependence in the first place, which means rethinking the current revolution in pain management and ensuring that everything HHS does in payments, prescribing guidelines, that is, everything we do, promotes healthy, evidence-based methods of managing pain. We recognize that executing much of the important work against this epidemic falls to states and local governments, and we want to partner with you and be supportive with you in implementing these best practices. The Secretary has been conducting a listening tour on the opioid epidemic. So far, he's visited 7 states to hear from state and local leaders, healthcare providers, first responders, and family members involved in this public health crisis. He has been personally touched by the stories of loss and suffering, but we've also been inspired and encouraged by what states are doing to help turn the tide. Our second clinical priority is addressing serious mental illness. About 10 million Americans have a serious mental illness, such as bipolar disorder or schizophrenia. We are committed to doing a better job of helping these people get access to effective, evidence-based treatment. Our third clinical priority is preventing childhood obesity. Almost 1 in every 5 American kids is obese. These kids are going to have serious health problems in the future. We have to do a better job of encouraging kids and families to eat right, exercise, and engage in physical activities. And again, we need to partner with the states in solutions to these critical clinical priorities that we're addressing. In addition to these clinical priorities, addressing the high cost of prescription drugs is a priority for the administration. Last week it was announced that for the first time in 5 years, the average premium for a Medicare Part D prescription drug plan is projected to decline in 2018. This is encouraging news for the nearly 43 million seniors who are enrolled in the program. Lowering drug costs is a key principle of the President's efforts to address our challenges in the healthcare system, and HHS is committed to doing all we can to increase affordability and accessibility of care. Reflecting this commitment, HHS has begun a broad effort to make prescription drugs more affordable, particularly for America's seniors. This announcement by CMS comes on the heels of a proposal released last month that would allow seniors to share in the discounted drug prices hospitals are already receiving under Medicare. I've talked a little bit about what we're doing at the Department of Health and Human Services, but I do want to mention a new expectation as to how we do our work. The Secretary wants us to be able to look back on his administration as setting a new standard for productive, fruitful partnerships. We all understand that the real innovators, the real problem solvers, are not just in Washington, D.C. They're all across our country. The President and our Secretary understand and appreciate that achieving health care goals depends on empowering states and local communities. To that end, the first joint action of Secretary Price and CMS Administrator Seema Verma, who many of you heard speak on Sunday, was to co-sign a letter to the nation's governors affirming the Department's commitment to ushering in a new era for the federal and state Medicaid partnership, where states have more freedom to design programs that meet the spectrum of diverse needs of our Medicare populations. States, as administrators of the program, are in the best position to assist the unique needs of their respective populations and to drive reforms that result in better health care outcomes. In terms of executing those partnerships, our office, the Office of Intergovernmental and External Affairs, is your front door to the department. We're here to help you decipher the department, whether it's arranging for a meeting, providing technical assistance, helping with constituent casework, or just answering your questions. We like to say that we don't write the stone tablets, but we go up to the mountain and get them and deliver them to the folks who need them. That was supposed to be a joke, you guys. I trust that we're not quite awake, but I trust that a number of you have worked with our IEA staff liaison to state legislators in our department, Jennifer Stowe. Jennifer, where are you? Would you raise your hand? She's a great resource for you after this session is over. IEA is also has an important presence through our 10 regional offices that directly serve state and local organization. A president-appointed regional director leads each office. Each regional director ensures the department maintains close contact with state, local, territorial, and tribal partners in addressing the needs and communities and individuals served through HHS programs. So for those of you in New England, our acting regional director for Region 1, Paul Jacobson, is here in the audience. Paul, where are you? Would you put your hand up? Paul's another good resource for you. If you're in Maine, Vermont, New Hampshire, Connecticut, Massachusetts, or Rhode Island, Paul's your man there. So, also, we've compiled a lot of information on your electronic materials, the list of the 10 regional offices. So let me just close by saying thank you for all that you're doing in your states. This administration and our team at HHS have immense respect for what state governments can do to advance our mutual mission of improving and protecting the life of our citizens. It's great to see groups like NCSL bringing people together to combat some of these intractable issues, and we recognize that you should have, because you have unique needs, you should be able to come up with unique solutions. So I look forward to being a part of your conference, to continuing to hear and listen and learn from you, and thank you again for allowing us to be a part of this morning's panel. I'll now turn it back over to Senator Peters. Thank you.
Thank you very much. So we're going to start and do a couple of questions here, but the first one I want to ask is based on the lack of bipartisan effort in the discussion of and the dialogue surrounding the issue with the Affordable Care Act and whatnot. This group of elected officials in this room is a bipartisan. Is there something that we can help with, or is there a lesson or a precedent or breakthrough that state legislators can bring working up from the state level to help you to do your job?
That's a great question, and I think the bipartisan approach obviously is the most sustainable, strongest approach that we've seen over the history of legislative action and good policy going forward. One of the breakthroughs that I think that in terms of a bipartisan approach was Alaska's 1332 waiver. And it took a bipartisan approach, obviously, in order to have enabling legislation. The state legislature had to come together, pass a bill signed by the governor, and then it went to CMS and was approved. 1332s allow states to provide, state innovation waivers provide the states to have flexibility. Alaska's problem was high premiums and not many people being covered, so they addressed that in their waiver, and it was a great bipartisan approach. So hopefully we'll see more of those kinds of efforts coming forward from you and the states.
Yes, congressional action is needed for funding for the CHIP program as of October 1st. So do you see any discussions going on to really move that forward so that we can see that continue without any interruption? And the states, I think, need to have some understanding that that's going to be able to continue in some way, and whatever the design is going to be, if it's going to change, so that they can react and not leave families and children in the lurch.
So the CHIP program, since its inception, has enjoyed bipartisan support. I mean, obviously we can't predict what the future will hold, but we do know that it has strong bipartisan support, and previous reauthorizations have occurred without significant controversy. And in the President's 2018 budget, he's called for 2 years of funding through 2019.
So you touched on it a little bit in your remarks about the opioid epidemic, and I know states, it's been a constant conversation here as far as what states can do. But what can we see, or what as state legislators, what can we help work with your office to maybe hold off? You know, I guess my question to your boss a couple months ago was, I think based on a pain management approach on how insurance companies are paying for the fun drugs that we like to fight with now, what can we do to help push that, or what's the time frame to kind of change how pain management is paid and reimbursed?
That was one of the listening sessions that Secretary Price had at the department, but also I said that he's in the regions and in the states listening as well. But the whole notion of pain management and rethinking how we reimburse around that. He likes to tell the story of, he just went to the dentist for some oral surgery, and his own dentist wrote him a script for a 30-day supply of opioids. And it was just like, no, I need Tylenol, you know. So what the states can do really is maximize your prescription drug monitoring programs. You all have them, all the states have them. Provider education is another really important thing. I know Massachusetts has done a great job with that, prescribing practices. But beyond that, making sure that you have safe, convenient places where people can dispose of their prescriptions that they don't need any longer. But I was with Kellyanne Conway when the Secretary went to Chattanooga, and what a great recovery community. They've really come together in some innovative ways, and I think that's what you can do in your states as well, is the kind of listening sessions, the round tables, raising awareness, just talking to people. When you're doing town hall meetings, talk to them about the statistics. I mean, I don't think a lot of people really realize how significant of a crisis this is. And Kellyanne said this is a crisis that it's a nonpartisan issue in need of a bipartisan solution. And I think if there's anything that we can come together around, because it affects all of us, is that this can be a bipartisan thing that we can all work on, and we've got to work on it. It's taking too many It's taking too many lives.
Well, thank you very much. We've got 4 folks. I'm not sure how we want to do it. Are the mics around, or do we want to bring them up? Assemblyman Mike Sprinkle? Maybe not. Oh, there he is. So, I know, it's helpful, right? Here. Why doesn't he can just, there we go. Perfect. I will call upon Assemblyman Mike Sprinkle from Nevada as a response to Ms. Horton.
In regard to the opioid specific? Okay. So specifically to that information, things that I've been working on for many years now, I think that you addressed the initial problem. We had a focus group earlier today, which really focused on the mental health aspect of it and how we really need to really start focusing more on addiction and stopping that long-term effect of opioids. We're starting to get a good sense as far as the prescription drug monitoring programs, as far as legislation to look at the prescribers. But that's kind of the next step, along with this blossoming problem with the illicit drugs, with heroin and fentanyl.
Thank you. And Representative Jim Dunnigan? Oh, there we go. Hello. Can I? Go ahead.
Sorry, I jumped the line. I apologize. Just a follow-up comment. I'm Senator Green from Hawaii. I'm an ER doctor. I
Okay.
prescribe these
Yeah, I know.
pills, though as infrequently as I can. Just a couple stats. I know some of you have heard these, but it's important to remember. We have 4% of the world's population as Americans, and we're consuming 80% of opioids by prescription. They're killing people, as you all know. We started the PDMP program in Hawaii. We made it mandatory that you sign up but not use it, and only 11% of our providers are using it right now. So it's just not, it's helping, but it's not penetrating yet, and people are only becoming aware, though we do expect to have success. We held a lot of work groups, but our citizens are just not aware yet that in Europe you take Tylenol when you've got pain, and in America you take pain pills. So I guess my reflection after working like many of you for many years on this is we're going to have to change society. We have to change doctors, myself included, but we have to change society because we are a shocking outlier in this space. And so you're totally right. It's not a partisan thing. It's a human thing in America.
Thank you. Jim Dunnigan, representative from Utah. I am so excited about your background and SEMA's background and Secretary Price's background from the states, and I just say please don't forget that. And Jen's terrific to work with. She really is. If the only approval we had to get would be from Jen, I think we'd be in good shape. I want to mention that Utah submitted an 1115 waiver a year ago, and that the waiver addresses, it provides to childless adults full Medicaid coverage, so it's part of the coverage gap, but it's a targeted coverage gap. When we worked with CMS last year and the prior year, they said, we'll give you more flexibility if you'll do it at your traditional Medicaid match rather than the enhanced match. So the waiver that we submitted was at our current FMAP. We want to cover the chronically homeless and those with substance abuse and mental health issues. Rather than incarcerate them and put them into jail, we want to divert them to treatment. The waiver's been in there a year. We tried to craft exactly how CMS directed it so we could get quick approval. And I'm just would like your help and your support to take a look at that. You know, SEMA said that she wants to change from the agency of no to the agency of yes and more flexibility and innovation. We are volunteering to be one of the innovators. We will accept a yes. I want to be very clear on that. And she says she's talking in months instead of years, so it's been a year. And in March, we got the letter from Secretary Price and SEMA, and they said, more flexibility, you know, give us your ideas. So we've adjusted and updated the waiver, just completed our new public comment period. A week ago, we heard from HHS, CMS, that said, if you want to add those little tidbits of flexibility that we encourage you to add, that's going to postpone your approval back several months from where it might have been. So we appreciate the offer of flexibility. Yesterday or Sunday, it was told by Calder and SEMA, it's kind of on us to come up with innovative ideas. We think we have, And now I think it really falls on your office to start approving and showing that we can get some of these waivers approved in a more timely manner. Thank you.
Hi, I'm Representative Sarah Copeland Hansis from Vermont. Just to kind of orient folks who may not be familiar with what Vermont has been doing in healthcare reform, I have now been in the legislature long enough to have been through 2 different attempts to move Vermont to a universal healthcare system. And each time we have fallen short of achieving that goal, we have stepped back and focused on what we know needs to be done anyway, which is to improve the delivery system and to try to contain the rate of growth of healthcare. And as you know, if human beings are not to be left to die on the streets from preventable illnesses, our best way to control the rate of growth is to make sure that people are getting the right care at the right time in the right setting, so that they can stave off downstream higher cost incidents. And so what we are doing right now in Vermont is really just continuing to work on our blueprint for health, which is the recognition that the 20% of sickest people are consuming 80% of that health care. If we can keep those people well and prevent other people from falling into that 20% of the sickest people category, we can control health care costs for the entire population, and we can improve people's quality of life and incidentally ability to provide for themselves and for their family. So we are moving towards an all-payer model, and the all-payer model, the goals of the all-payer model will be to improve the patient experience and to streamline the delivery of care, but also to contain the rate of growth of per capita healthcare spending. And that, I think, is going to be the next phase of focus in Vermont, is to continue to work towards that type of system of care. And I guess the question that was posed, when I was asked to prepare for this is, what would we ask of our federal partners? And so I guess, you have already pledged that your administration would like to give states the continued flexibility to innovate, and we thank you very much for that, because we and many other states are trying to be incubators of new ideas on how to fix healthcare. There are 2 other things that I think we need. One of them, very critically, is that we need the stability of funding that we have had in this state and federal partnership through Medicare and Medicaid program. We need to be able to know, going down the road, that as we are working so hard to contain the rate of growth of spending, that we're not going to end up pulling the rug out from underneath people, which will cause some of our most vulnerable populations to be at risk of falling into that very sick category. And then I guess the third thing I would say that we would love from the administration would be a really strong push to allow for all publicly funded health systems to be able to negotiate for prescription drugs. We spend an inordinate amount of public tax dollars on prescription drugs for our population, and it would be fabulous if we could negotiate collectively for that. So thank you very much.
Thank you. Representative Hunoff, do you want to grab the mic from her? What last question, Representative Hunoff, and then we have to move on. There she is. Perfect. Thanks.
Great. Thank you. Representative Jean Hunoff of South Dakota. In the comments that have been made, we talk about flexibility for states, but part of that is there's not a unique model that fits every state, and part of that flexibility looks at the regulatory side, which becomes very cost prohibitive, especially in the provision of community-based services. And so as you continue to deal with the red tape, the documentation, the submission, the paperwork, the endless, that adds to the cost of delivering the service, and also in the kind of provider that can be prepared out there, and not mandating that it has to be a educational preparation of some sector when you're looking at, because you've got to tailor our lack of a workforce to a workforce that can deliver. So I would hope as you move on into this flexibility for states that as we write those waivers, we can look at that regulatory side and allow us to adapt to a model that will deliver the services that we need, especially in a frontier state for health care. Thank you.
All right. Thank you very much. Yes, absolutely. Thank you. And with that, I'm going to turn it back over to my good friend, Senator Dick Moore.
I'd like to make a
Oh,
comment before we
excuse-
go to the Senator.
Sure, go ahead. There you are.
I'm State Representative Dave Heaton, and I'd like to talk about the 1332 waiver request. Iowa is one of the states that is down to one provider. Did you say Iowa? Iowa. And we're down to one provider. And if we don't get a request for our 1332 waiver honored, we will lose that provider, and we will be there with no insurance in our state for individual policies. Our insurance commissioner has sent in the request. It's been there, and I think it's been in there for about a month, maybe a month and a half. And we realize that this is a temporary solution. We understand that. But we need the federal government to make a real permanent reforms to the ACA if we are to save the health insurance options for our farmers, for our small business people like I used to be, and those who are retired before they get their Medicare. These people will have no health care. So in terms of what Iowa needs, we need your approval of our 1332 request. The other major issue for us is Medicaid. We are in year 2 of using managed care for our program. It has been successful in breaking the Medicaid cost curve in Iowa, but as Washington looks to reform Medicaid, we need everyone to remember that this program has significantly different cost drivers. In Iowa, seniors and the disabled represent 25% of the enrollment, but consume 70% of the funding. We must learn the lesson that from the creation of TANF, that there needs to be a reasonable growth factor built into the system if it is to be block granted or switched to a per member per month formula. Without that, it would be very difficult to maintain the needed level of services to these most vulnerable Americans.
Thank you very much.
The check is in the mail, Dave. If I could call up our next panelists and thank Jane Norton for her remarks. If we could have Kim Holland, who's Vice President for State Affairs for the Blue Cross Blue Shield Association, Joe Antos, Dr. Joe Antos, for the Healthcare and Retirement Policy of the American Enterprise Institute, and Chiquita Brooks LaSure, who's Managing Director of Manat Phillips LLP. The focus of this section of the panel will be primarily on the impact of the health reform on the insurance market and various aspects of that. Obviously, one of the issues that affects insurance is that we didn't get into yet in the priorities from the administration are cost containment as well of health care itself, because those are building blocks of what the insurance policies call for. We did do some work on that in Massachusetts, and the state auditor was commissioned to do a study and has determined that that cost containment legislation has made some progress, but we still have a ways to go because the cost continues to escalate beyond normal inflation. But with that, let me start with, I don't know who would like to start first. As Chiquita? All right, go ahead.
Great, thank you. It's a pleasure to be here with you today. Thank you so much for the invitation. As we all know, as Senator Peters was just remarking, it's been quite a roller coaster these last couple of months, waiting to see whether Congress would change and replace the Affordable Care Act, particularly focused on changes to the individual market and the marketplaces. And for now, with Congress out of D.C., back at home, things are really at a pause at a really critical time. As you know, insurers are in the process of finalizing their rates along in talking with the states, as well as deciding whether or not they're going to participate in the marketplaces. So I'm going to focus very briefly on a couple of the key issues that face the Trump administration, as in the short term, the Affordable Care Act is continuing as is. There are, of course, very important reforms that Congress should be considering, as well as states, but I want to mention these three things. First is marketing and outreach, and it's not something that has been a big part of the congressional debate, but as we all know, one of the key issues in the individual market is attracting young and healthy risk to have a balanced risk pool. And there are requirements in the Affordable Care Act for responsibilities of HHS to enroll individuals to make sure that they can get their determinations. But a lot of that, the marketing is really up to the discretion of the department. And it's going to be and continues to be a key issue as we move forward in the open enrollment period for 2018. The second issue to mention are the mandates, the individual and the employer mandates. Experts disagree on how important they think the mandates are for ensuring a healthy risk pool, but at least some insurers think that it's important and included as part of their thought process about how they set premiums. And then the third issue, which is by far the most critical and most important, especially in the near term, are the cost-sharing reductions. As part of the Affordable Care Act, when people purchase insurance, some individuals, based on their income, get assistance through tax credits, which helps pay for their premiums, and cost-sharing reductions help pay for out-of-pocket costs. So when you go to see the doctor, when you get your treatments, etc., and those are available to people between 100 and 250% of the poverty level. Those individuals are entitled under the law to those reductions. And so the uncertainty about whether those payments are going to be made has caused a lot of insurers to cite that as a reason why they may not participate in the market, as well as, thinking about increasing their premiums, estimate between 10 to 20% based on whether or not the cost-sharing reductions are paid. So these are three very important short-term issues. Again, they're things that we should we'll talk about the course of the panel, that Congress should consider, and things that states across the states, the marketplaces are in different states, and things, as we've mentioned, different states are considering to stabilize their markets.
We're going to perform an experiment. Oh, it did work. Okay, well, I'm surprised at how many people came in today. It's quite a huge crowd. I'm going to focus on some of the same issues, but from a slightly different perspective. The Affordable Care Act established an important new norm of social policy, which is this idea that everyone should be able to buy insurance regardless of their health status. That isn't the way the individual market used to work. Is this right? Okay. Yeah. I think that one works fine. Yeah. Yes, it does. The individual insurance market was, in fact, perfectly stable in a way that I think most people would find unsatisfactory prior to the ACA. Insurers had businesses that actually could make money, but that was because they could also exclude people with serious conditions. They could charge higher premiums for people who are going to spend predictably more money and so on. What the ACA did was basically say, okay, we want a different social norm. If you're going to have a different social norm, you also have to take into account what that does to the market, to the business of health insurance. And I think that's one of the failures of the Affordable Care Act. So in a sense, switching the rules without taking into full consideration how insurance actually works destabilized the market. The ACA destabilized the market. Now, one of the things that the Obama administration emphasized, especially last year when premiums went up 25% for the current plan year, was that I think the phrase was no one would pay more. Well, that's not exactly true, but it is true that people with subsidies received subsidies that went up dollar for dollar with a premium as long as they stayed with the second lowest cost silver plan. But somebody did pay more, that's the taxpayer. And that gets to the real problem with the U.S. health system, the incredible inefficiency, waste, and overspending that we have in our health system. So the Affordable Care Act focused on including more people in insurance coverage, but did not really seriously address the cost part of it. Republicans have bitten off, I would say, more than anybody can chew, because essentially they raised their hands and said, okay, we'll solve the cost problem too. And as everyone here knows, the cost problem is not solved easily, and generally not solved by Washington legislation. It's resolved in ways that require working on a daily basis at the local level. States can contribute to that. They can contribute to stabilizing their insurance markets, but they can also contribute to helping the costs slow down by having less restrictive requirements for who can provide services, for example. Lots of other things that states could do. But with that, let me turn it over to Kim.
Good morning, everyone. I have spent my entire career in the insurance business. I was a small business owner in Oklahoma. I ran a multi-lines insurance agency there, and my discipline was employee benefits. So I worked with small and large businesses on selecting health insurance products. I did that for about 25 years before I had the opportunity to serve as Oklahoma State Insurance Commissioner, which is an elected office, and served in that capacity for 6 years before joining Blue Cross Blue Shield. So I like to tell people that in those capacities I have bought Blue Cross, sold Blue Cross, regulated Blue Cross, and now work for Blue Cross. And I can tell you that at every one of those different perspectives, things are very different. This is an extremely complex environment, healthcare itself, and health insurance is no exception. It's very, very complicated. I can tell you one of the prevailing things that I have learned in all my years of experience is, as a business, the insurance industry can pretty much respond to whatever the rules are. They can run their business based on whatever the rules are. They just need to know two things. What are the rules? And that everybody plays by the same rules, right? Those are the two fundamental issues that we care about as a business. Our business, don't kid yourself, the CEOs think they run the business, actuaries run the business, right? And actuaries, by their very nature, are conservative people. They are there to determine risk. They are there to ensure the solvency of our industry. As an insurance commissioner, that was my principal responsibility, to ensure that companies remained solvent so they could fulfill the promises that they were making to their policymakers. And that's the actuary's job. They look at a lot of different factors to make those decisions, right? They look historically at claims. They look at the benefits that they are that they're providing. They're looking at medical trends, but they're also taking into consideration existing federal and state laws and regulations. And when all of those things are in flux, or any one of those significant things are in flux, they take the most conservative route. They are going to price for the worst case scenario, and that's what you're seeing today. The second part about that, in terms of level playing field, that's when competition is at its best. That's what regulation is about. It's not to micromanage a company, but to create the guardrails so that a market can function effectively, where everybody does play by the same rules and we can have a true sense of competition. When regulation or laws pick winners and losers, that's not competition, right? That's winners and losers. So we have to get back to an environment where the market is effective, because companies are allowed to compete fairly and understand the rules, and the rules apply to everyone. Thanks.
I think one of the things that folks in the audience might like, particularly the legislators and staff, might like to know is if you have some specific suggestions of what the states could do, either to help the insurance companies keep the cost within some degree of reason, or to help expand coverage so that areas that are not well served get that kind of support. Let me start with you.
you want to start with me?
Well, just a couple of things that come to my mind, and I heard Chiquita mention something about marketing. We know that the administration has reduced or cut back the promotion of health insurance. I'm just going to tell you that the best opportunity we have to lower costs overall is to get more young people in the pool. I know that probably sounds like a broken record to a lot of you, but until we get, the whole principle of insurance is spreading the risk. The young people pay for the old people. We're all going to get old someday. The closer I get to it, the more I hope there's more young people in that pool. So it's a benefit to all of us and a benefit to costs overall if we ensure that young people are in there. But let's face it, if I'm a 26-year-old, 27-year-old kid that's just gotten off my parents' health insurance plan, my most important thing is whether I can pay my cell phone bill. It isn't about buying insurance. So we're going to have to figure out a way to entice these young kids to buy insurance and understand it's their responsibility to do so. That is not a new problem, right? It's a long-standing challenge. We've not met it head-on yet. So anything you can do to help promote young people buying coverage is going to help everyone overall. I really appreciate the comments about 1332 waivers. I heard Jane comment on Alaska today. We've been very involved in that situation, but let's face it, they redirected all their premium tax to get that waiver. And I would suspect for most of you that would be a heavy lift, right? Premium tax generally is the second or third largest contributor to your state general funds, and it's going to be really hard to put that money aside for that purpose or any part. Idaho is an example that I think is great. I don't know if anybody's from Idaho in here, but Insurance Commissioner Dean Cameron, who is a former legislator, great guy, he was very innovative some time ago and said, well, you know what, after premium tax revenues exceed a certain portion, we're going to redirect that excess into a high-risk pool, right? So over the years, that high-risk pool has built dollars up that are now they're considering as part of their waiver to help fund high-risk claims. Because if you can create a pool that can offset the claims of high-risk individuals, that's another opportunity for you to get costs down. Not an easy thing to do because, again, you've got to have the resources to do it. But working with HHS, if there are ways in which they can provide and help you create creative solutions, that's another thing. Third, I would just say, first and foremost, do no harm. Remember what I said about level playing field. Consider the potential impact and consequences of the decisions and actions that you take that might inadvertently create adverse selection. So do listen to your insurance companies. I know insurance companies are all our favorite people to hate, but the fact of the matter is, in each one of your state, they're taxpayers, they're good corporate citizens, and at the end of the day, we just want to make sure people get the coverage and the care that they need. There's experts within those organizations that can help you craft policy that can go a long way to advancing your interests in protecting your constituents.
Okay. So other things that states have done, as you know, Ohio went from 20 counties that had either none or one, I think it was none, insurers in the exchange market down to one county that is still without an insurer. You know, there are ways that states can do this. They're usually punitive ways involving a little bit of arm twisting, but certainly the idea of expanding the rating areas so that the good rating areas, the rating areas where there is a pretty sizable urban population, spread those out past the suburbs and pick up a county that is a low population county is one way to do it. That expands the risk pool, that makes that larger area a somewhat more viable commercial proposition. What it basically means, however, is that the people who are already buying insurance, already had lots of options, they're going to be paying a little bit more. But that is the essence of insurance. That's one of the things people don't seem to understand. It has something to do with sharing the cost. When we say risk, people don't seem to understand that. It's sharing the cost. And so that's a mechanism that works pretty well. A more punitive method is to basically say, if you don't go into the exchange market, you can't participate in our Medicaid market. I don't recommend that because that's a market that has its own problems, and that's just shifting problems from one area to another.
And I'll just really echo again, I think what Kim said, being incredibly important, marketing and also the reinsurance. Alaska's waiver, obviously a model that HHS is incredibly supportive of, and has the added bonus of adding federal dollars to state dollars, a very effective way. The Affordable Care Act had a reinsurance program that was helpful for reducing premiums, and it may be an option for other states. I would just add that, again, it really varies across the country. As you all know, different states are in different positions about what's going on with their market, and so knowing what's going on with your local market is key. But for some states, Medicaid may be, leveraging Medicaid in one way or another may be a viable option. Joe mentioned tying and some of the drawbacks. It may be more appropriate for a state where there is an incredibly robust Medicaid managed care, so not necessarily effective in a state where managed care isn't as prevalent, but there are some states with significant managed care pieces, and other ways to leverage Medicaid. Arkansas, of course, with its premium assistance program, brought more lives into the marketplace.
We've got an opportunity for some legislators or legislative staff, most of whom, a lot of whom are gathered up front here, but if you're one of the shy ones sitting further back, please raise your hand and we'll try to get a microphone to you. Why don't we start with this gentleman on the first table here.
Thank you. I'm Mark Levine. I'm a member of the Virginia House of Delegates. Kim, I found what you had to say very persuasive, and I have a question about certain Trump administration priorities and how they affect rising premiums. So specifically, you mentioned not advertising the exchanges, that you felt that made fewer young people in, and that raised premiums. And then the second thing I want to know is enforcing the penalty. Apparently they're trying to enforce it less. Does that raise premiums and encourage people to desert the market? And the third, and I think the most important, which we haven't discussed, which surprises me, is the failure to obey the law under the Affordable Care Act that insurance companies are going to be compensated for the subsidies that they pay. Now, they've paid it on a month-by-month basis, but the law says it has to be paid, and the Trump administration is wavering over whether or not they're going to pay it or not. Does that uncertainty increase premiums and cause more people to leave the market? And in essence, given that Congress has failed to do anything, if the administration were to support the Affordable Care Act as it currently exists, rather than trying to, some people aren't going to like this word, but sabotage it or make it implode, would that indeed lower the cost of insurance and cause more people to stay in the market?
Lots of questions. So let me just say, first, I think there's always a legitimate debate that should occur about the role of government in something as personal as our health care, right? I think that is a totally legitimate debate. So, but that's not what I'm here to do today. So what I'd like to just give you some factual information in response to that. The issue with young people and marketing, that's, as I said, that's been a long time problem. That didn't get created with Obamacare, and it's not going away with Trump care. It's been a long time problem, right? But it leads into, very importantly, something that you're not going to like to hear, but I'm just going to tell you. The fact is, if we do not have enforceable continuation of coverage requirements, whether at the state level or the federal level, we are never going to have a healthcare system that balances and does what we need it to do in terms of ensuring that when we get old and we have those big claims, that we're going to have the pool of funds necessary to pay those claims. If you think about it, if you drive a car, most of your states have passed laws that people have to have car insurance. If you go down and borrow money at a bank to buy a house, your bank is going to require that you have homeowners insurance. If you are not on Medicare today, but your parents are, they're mandated to contribute to Medicare. All of those reasons are for social purposes, right? It's to create a funding mechanism. If you don't pay health insurance, you're going to get sick someday. I promise you, none of us are free from that. You're going to walk into an emergency room, and if you cannot pay the bill, who's paying for it? the taxpayer's paying for it, or I am paying for it through higher premiums. Is that fair? I don't think that's fair, right? So we all have to acknowledge we have a personal responsibility to pay for the care we receive. Now, the debate becomes, how do we do that, right? And I'm not here to debate those issues, but I really encourage you as state leaderships legislators to take the lead on this. Recognize that this is not a political conversation. This is a social responsibility and personal responsibility conversation, and we need to figure it out.
Thank you. Rick Stark from Florida, State Representative. Question I have to ask, well, first of all, I think that most of us agree today that, we're the last of the Western nations to really be pushing for some type of universal care for all of our citizens. And I like the Affordable Care Act and the fact that it was attempting to use the marketplace in order to accomplish that, instead of going toward a completely socialist model. My question is that there was a taken away of what was called a risk corridor to help insurance companies during the early phases of the Affordable Care Act to stabilize, because as we went to guaranteed health insurance, the insurance companies could not necessarily, this is at least on the individual side, manage all of the claims that they were getting. This is what the term adverse selection is. And as much as I like my friend from Blue Cross, we have in Florida 49 out of 67 counties only have Blue Cross. And certainly having more competition is what we're trying to do, using the marketplace as it is. So my question is, Blue Cross, you can answer for me, but creating a stability fund that states can use to reduce premiums, do you have a comment on that? Changing the definition of full-time hours to 40. Certainly clear guidelines on the 1332 waivers. And I've got a few things here, but also maybe getting rid of the Cadillac tax, and also maybe a full repeal on the health insurance tax. How do you feel that would do to stabilize the marketplace and bring in more competition?
Chiquita, you want to...
Sure, I'll start. I think that what we are seeing, some of the key issues that you talked about are things that really are going to require congressional action. And one of the first points, talking about a stability fund, making that available to states, was something that was part of the repeal and replace discussion. And if we see in September a move and a push to bipartisan conversations to stabilize the market, I think those ideas will be a key part. They certainly are. They were part of the original Affordable Care Act, built on the Part D model, very effective. Reinsurance risk corridors, I think of these as similar. They are not the same, and they have different effects. People are more attracted, I think, to reinsurance because it's more likely to affect premiums. But these are all ways to help increase and stabilize the market, and need to be very seriously considered, and are probably very necessary moving forward. There are a number of ideas that I think are critical, and hopefully Congress will be amenable to supporting some of these.
Anyone else, Joe?
Yeah, so in a way, we're talking about a shell game here, because although people like to say that what we need is young, healthy people to enroll, what we're really saying, and Kim more or less said this, is that we really want everybody to pay. The ideal situation for an insurance company is to have people pay and not use services, right? So we're really talking about a financial game. I'm not arguing that you don't need compulsion. It's having been a young male myself, I wouldn't have bought insurance. It wasn't my cell phone. My bar bill was probably more important to me. But the idea of social responsibility really starts at the home. It doesn't start with the federal government. It sure doesn't start with the state government. Really, people have to get over this idea that that we still have, that unless you do something, you're uninsured. We have to get the idea that unless you do something, you're insured. So there are conservative ideas that involve something called automatic enrollment. There are lots of ideas like that. One aspect of the 3 Rs, though, that you want to be careful about, a number of the more profitable plans in the first few years of the ACA ended up losing money because they had to shift tremendous amounts of money, basically all of their profits, to the companies that didn't do well. They tended to be the companies that were the big name companies. So you want to be careful about how you set this up. That was one of the problems with the ACA originally. A lot of these things sunsetted. That was a bad idea, and many of them weren't thought through all the way.
Yeah, and I just briefly on the 3 Rs, just so you know, were the risk adjustment programs that the ACA adopted primarily to ease the transition, recognizing that we were going to from a market where insurance companies could deny coverage, right? They could underwrite and decide they're going to cover somebody. They could limit, and we're talking only the individual market here, right? To a guarantee issue, no pre-existing condition. So what was recognized is that transition was going to be really costly, and people were going to go to the market. They were going to pick a plan. Remember those actuaries? There was no way they could really determine how many people they were going to get and what the risk was. That's what risk adjustment was intended to do. And it shared money from insurance company to insurance company. The risk corridor program was insurance company to insurance company with a backstop of the federal government, recognizing what Joe said, that, you know, it could be the first year there's going to be more people losing money than making money, and that means that there wasn't going to be enough money in that pool. The reinsurance program to take into consideration that there are going to be people that have not been able to get coverage, were not eligible for other plans, that were going to go into the market and probably had really high pent-up claims. People with cancer. I mean, I know within our system, we had a number of people waiting transplants that, you know, come January, they were covered, right? So large claims. That's what that was supposed to mitigate. And then finally, risk adjustment. Those two programs went away, right? Then risk adjustment stayed there, and that means we don't know what risk we're going to get. We're pricing our products, it's going out on the exchange, all the prices come out at the same time, people pick their coverage. We don't know if we're going to get all the sick people or the well people or what. And so that risk adjustment gives money back and forth to insurance companies. So all of those things, none of them were bailouts, right? None of that. It was all how do we share the costs around the entire system, recognizing there are different players in there. And the programs, for a variety of different reasons, whether it's congressional action or inaction or whatever, as Joe said, in some cases it's just like, okay, in hindsight we might have tweaked this or done something differently, have created some challenges for the industry today.
We need to move on to a little discussion of Medicaid and CHIP, and so I want to thank our panel for their efforts.
So just like in NCSL fashion, we're going to switch topics and switch speakers really quickly. To accommodate our legislators' ADHD, we have to switch topics every 30 minutes, or we have a tendency to lose attendance. So in order to keep the room full, we're going to switch topics one more time. So I think they're going to put up the list of the next two. Yeah, there they are. So we've got Sarah Rosenbaum and Barbara Anthony, and we're going to talk about, in a nutshell, what's going on with Medicaid, I believe. So with that, ladies, I'll let you take it away.
It's like speed dating.
It is.
Absolutely. Is this mic working, or is it the other mic that's working?
The other one.
Okay. All right. Good. So, you know, if you do this kind of speaking, you're always looking for analogies that sort of help you lay out a picture with as few words as possible. I've spent about 40 plus years now. Ooh, you're okay. 40 plus years on insurance law, and I would say that I've come to think of the individual market as a true hothouse flower. I mean, something that needs a lot of tending, as you could tell from the previous panel, to make work. Medicaid is a very interesting program. It is what I would think of as a hardy perennial. It is a program that is built to embrace risk. What I mean by that is not its size, scope, complexity, but it's a program that is designed to embrace risk. It is truly a public health program. It functions like insurance, but it is a workhorse of the first order for every state. There is, of course, no single Medicaid program, but a cluster of 51 state Medicaid programs and then many territorial programs. And even within a state, of course, the Medicaid program is different from between urban and rural areas, from county to county. Program can look very different. It is carrying such a burden today. I'm sure you're all familiar with the statistics. It's 50% of all births. It's 40% along with CHIP of all children. It's the way we support neonatal intensive care units. It's the way we support our children's hospitals. It's the entire long-term care system of the United States at this point. From a practical perspective, it is the way in which we have made it possible for disabled children and adults to live in the community. And it's huge. It's about 75 million people. If I had to identify what I think are the big issues facing states today, they would be as follows. The first one has to do with, in fact, one of the observations made by one of the representatives during the questions for Secretary Norton, and that is that this is a program that, despite its size, runs very close to the bone. It is a program whose size is predominantly explained by its enrollment, and of course Medicaid enrollment is, if you stop and think about it, it's simply a reflection of so many things in our society. It's a reflection of childhood poverty. It's a reflection of adult poverty. It's a reflection of an aging society. It's a reflection of the remarkable strides we have made in enabling people with very, very serious health conditions to live in communities and to live a long and productive life. That's why Medicaid is big. So the question is, how do you manage such a big program? A second big function of Medicaid, which I think is something that was poorly understood and has really come to the forefront in the Affordable Care Act, is it is a shock absorber for the private insurance system. It does a lot of things that private insurance simply cannot do. You cannot ask, whether it's group insurance or individual insurance, to take on responsibilities that don't lend themselves to the kind of pooling mechanisms we use for private insurance. It's a public health function. And Medicaid, I think, really has reminded us of the importance of public health. And that has to do with everything from ensuring the poorest and most health vulnerable people in a state to paying for things that just are beyond the limits of private insurance. And that brings me to the third and most, I think, that the toughest challenge in Medicaid, and that is that Medicaid agencies no longer are, and they haven't been for a long time now, are payers of claims. They do that, of course, just like any insurer would. But they are really the linchpin in creating delivery systems that work for low-income and medically vulnerable populations. There is no insurer that I'm aware of whose responsibility for tackling payment and delivery reform even comes close to Medicaid. I started my first managed care studies of Medicaid programs back about 30-some-odd years ago. I'm just completing one now for the Commonwealth Fund, and I am continually blown away by the degree to which Medicaid agencies really are just core to delivery of care itself. And I think, and we'll get into this during the Q&A, that the biggest challenge for states now is finding a very practical work partner in the federal government. I don't care who's in charge of federal policy, but the issue is finding a partner that's willing to help states make the kinds of pragmatic decisions they need to make to achieve delivery of care.
Thank you very much. Good morning, everybody. I'm Barbara Anthony. I'm a healthcare policy consultant with the Pioneer Institute. Some of you said to me, what's Pioneer? Pioneer is a Boston-based think tank. It promotes market-based solutions to public policy issues, whether it's transportation, education, health care, or whatever the issue might be. And before joining Pioneer, I was the Undersecretary of Consumer Affairs and Business Regulation for the Patrick administration here in Massachusetts. It had a great deal to do with insurance, particularly health insurance. So it's a pleasure to be here. Thank you, NCSL, for inviting me. Let me begin. My charge, as I understand it now, is to give you all some information about what Massachusetts is doing in the Medicaid sphere to try to reduce costs, what has been done, what's ongoing, and what is proposed. And I'm also going to talk a bit about the commercial market. You've heard Senator Moore, and I know some of you heard David Seltz, the Executive Director of the Health Policy Commission, who's here, talk about the Health Policy Commission and the state benchmark, so I want to get to that as well. So my role today is I'm a messenger. All right, so I'm just, I'm delivering messages. When I do express an opinion, it will be my own, and I will stand by it. So first of all, let me begin by saying that Massachusetts as a state, as a commonwealth, regardless of who sits in the corner office, is a state that is committed to near universal health coverage and health access for all of its citizens. So what have we done to get to that place? Back in 2006, as most of you know, Massachusetts passed its own version of health reform, which is popularly known as Romney Care. And that then served as a blueprint to the Affordable Care Act. We then participated in 2010 in the Medicaid expansion that was afforded under the Affordable Care Act. Now, since 2007, Massachusetts, like many states, has seen a dramatic increase in enrollment in its Medicaid population. Here we call Medicaid Mass Health. And so since 2007, our enrollment has increased 70%. So in these 10 years, spending has doubled. Medicaid is the primary insurer for about 1 in 4 people in our population, and it consumes about 40% of the state budget at about $15.6 billion. So what is the state trying to do about this, about trying to contain the cost of Medicaid, which some folks believe is reaching unsustainable proportions? Let me say at the outset that public officials here, from what I've heard, and I haven't heard anything to the contrary, no one is talking about walking back our commitment to near universal coverage. So you can see that there's a great challenge here, how to contain these costs, but to continue to provide the kind of coverage that we believe our citizens are entitled to. First of all, Governor Baker, who's been in office now I think for about 2.5 years, made a priority of addressing program integrity. Everybody talks about doing that, but I think this administration has done a pretty good job of ensuring that only those who are eligible are enrolled in Medicaid. It's time-consuming, it's expensive to do, but it's fair. It's the fair thing to do for everyone. Secondly, and very importantly, Mass Health, or Medicaid, is moving away from fee-for-service payment toward payments that are based on a set amount of money per patient and that place downside risk on providers. This is going to begin in January of 2018. Under this model, 18 accountable care organizations will cover about 900,000 of the almost 2 million people in Mass Health. This program is made possible by a $50 billion, with a B, dollar waiver that the state signed with the federal government a few years ago. The goal is to incentivize providers to keep patients healthy so they'll need fewer services and also cut costs. Now, most recently, the state legislature, and there are some members of our state legislature here, Senator Chandler, always great to see you, and other staff of the Health Committee I see, have passed 2 revenue-producing assessments on the business community if you have 6 or more employees. And those revenue assessments right now are targeted to bring in about $200 million to our state budget. This helps to reduce the Mass Health expenditures. There is one in particular that I think is really interesting and important, and that is a new assessment on employers whose employees choose to enroll in Mass Health rather than the company's insurance plan. So there's a new assessment on employers with 6 or more employees whose employees do that. Both of the assessments that the state legislature passed have a sunset, 2 years, and then they're gone. All right. I remember when I lived in Manhattan after 9/11, Mike Bloomberg raised property taxes for 3 years in New York. His popularity level went down to 27% overnight. But in 3 years, New York was back on its feet. It was a sunset provision, property tax increase was gone, and the economy was moving forward. So I think these sunset provisions, there's something to say for them. They have a way of sort of kicking things forward. Now, Governor Baker also made some proposals that did not pass the legislature. So these are proposals that the legislature is going to consider. First of all, shifting a total of about 320,000 non-disabled adults from Mass Health into commercial plans or to another Mass Health product. There are no premiums involved, but there will be co-pays and deductibles and some changes in coverage. All of this is designed to maximize federal subsidies. A federal waiver is required. Another thing that has been proposed is that we prevent non-disabled workers from accessing affordable employer-sponsored coverage from enrolling in Mass Health. That needs a waiver as well. There are a couple of other proposals that I think are just worth mentioning. They don't deal with Medicaid. They deal with market reform and cost containment, particularly on the commercial side, a moratorium on state mandates, beefing up our state's price transparency laws, expanding the scope of practice for medical professionals such as nurse practitioners, podiatrists, and establishing a new class of professional called dental therapists. Thank you, Senator Chandler. One word about, you heard me mention the Health Policy Commission in Chapter 224. In 2012, Massachusetts passed a law that said that health care expenditures in the state, total expenditures, public, private, commercial, everything, cannot grow faster than the state's economy. That's called the benchmark, and it established the Health Policy Commission to monitor and to enforce that benchmark. It also required price transparency by carriers and by providers, and a lot of monitoring by the Health Policy Commission of mergers and affiliations. So I'm happy to answer questions. Sorry I took a little bit longer than I had intended. Thank you. Thank you very much.
Fantastic. Well, I have one question for both of you, and it basically talks high level. Now, elephant in the room question here, but based on some of the information that we heard from our good friend Jane, how do you think states can help CMS modify or modernize the Medicaid program? Give us maybe one quick example of something creative that states can do to help CMS modernize the Medicaid program.
Is this the one that, yes. This, of course, is the $564 billion question. I have to say that I fundamentally disagree with the premise that Medicaid is not a modernized program. Medicaid has been remarkable, absolutely remarkable, at sort of reshaping itself over 50 years as the needs arose. I mean, whether it's the opioid crisis we're talking about, or special ed services, or Zika, or you name it, I mean, it's Medicaid everybody turns to. Now, within Medicaid, there are some huge challenges. I mean, I would put at the top of my list the challenge raised earlier, I think it was by the representative from Vermont, which is the obvious places where state Medicaid agencies probably could use a fair amount more latitude. One has to do with making alterations that bring the program into line with other payers, the other having to do with prescription drug pricing. And I think the great challenge that states are all confronting, and it's the toughest from my years on the Medicaid and CHIP Payment Commission, I would say this was the toughest thing we dealt with, was what to do about long-term services and supports. That is, being able to develop, manage long-term service and support systems.
Well, you know, this is a very good question and a really tough one too, because it comes down to what's the overriding philosophy here. And as I said earlier, Massachusetts, we've been committed to near universal coverage since 2006. But before that, we had all kinds of market reforms. No, guaranteed issue, no pre-existing conditions, community rating. So it's been a gradual slope upward for us in terms of fulfilling this commitment. But in terms of states and Medicaid needs, I mean, I think flexibility is incredibly important. Here in Massachusetts, we have definitely, through Medicaid waivers, taken advantage of creativity and ways in which to use Medicaid dollars to stretch them further and to maximize federal subsidies. I think the real challenge here is that as a nation, we have states that may have one set of goals and policies, and we may have a federal government with not necessarily the same goals and policies in mind, and there's a misalignment there. And so when we talk about flexibility, we also, quite honestly, we need to continue the federal dollars that we have been depending upon that frame and that help us provide healthcare services to our populations. I mean, the bottom line is this: there's no free lunch in healthcare. It costs money, and if people don't have access to healthcare, the thing that happens is that they end up in somebody's emergency room. We used to have that in Massachusetts, and we used to have a great big pool of money that was paid out to hospitals who had to care for people who were in emergency rooms. We don't do that so much anymore. We don't want to go back in that direction. So there's no, as you know in that movie, There's No Way Out? It's an old movie with Kevin Costner. I love it because I used to live in the River House, which is in the movie. If you've watched it, it flies over Northern Virginia. It's a great movie. But there's no way out. There's no free lunch here. The problem right now may be a misalignment in terms of goals and priorities, but flexibility is key.
Thank you. I think we've got time for one question. So who's the lucky contestant? Anybody? I'm not seeing any hands jump up right away. So with that, we'll thank these lovely ladies, and thank you very much for your time. Yep, yeah, not a problem. And we're going to move on to the next speed dating topic. So thank you all.
So if we could ask Ken Preedy and David Woodmansey to come up and talk a little about the role, the view from the stakeholders. Mr. Preedy is the Vice President for Commonwealth Care Alliance, which is kind of a hybrid nonprofit based in Massachusetts, representing companies before Mass Health and the federal agencies. Mr. Woodmansey is with the American Cancer Society and will speak not only from the standpoint of those with cancer, but other major health issues, serious health issues as well, because he's got a pretty good scope of what the other high-risk, high-cost treatments are and how they get impacted by some of the discussions with health reform that are going on. So I think we'll start with Mr. Preedy.
Thank you. I appreciate having you all here in Boston. I'm new to Commonwealth Care Alliance. I have been here about 2 months, so if I have to use some notes to talk about the game plan we have there, I apologize in advance. I also apologize for being the last two people who are between you and your lunch, so we will be as fast as we can. We were talking about going last on a panel like this. It's a little daunting to come in and talk about Medicaid after Sarah Rosenbaum just talked about Medicaid, or to talk about the role of the federal government when Jane Norton was up here. But I want to tell you a little bit about Commonwealth Care Alliance. I've worked in D.C. in Medicare and Medicaid policy for 20 years, and I've always said that Title 18 of the Social Security Act and Title 19, which are Medicare and Medicaid, they don't get along very well. They're right next to each other, but they're like neighbors who can't decide where the fence line should be. When I started to come work at Commonwealth Care Alliance, I realized that those two programs, Medicare and Medicaid, really do have a role to function together. You know, there's 9 million Americans approximately who are duly eligible for both Medicare and Medicaid, so they are the most vulnerable citizens of our country. 20% of those folks, so about 2 million people, make up 67% of the total cost of Medicare. So if you want to talk about innovative solutions to solve health care in America, I'd focus on those 2 million people first, because they're the ones who are spending the most money, and that's what Commonwealth Care Alliance here in Massachusetts does. We are a not-for-profit health plan, but we're more than a health plan. We are really 3 companies in one. We're a risk-taking managed care plan based here in Massachusetts, right here in Boston on Winter Street. We are also a care management and case management company, and we're also an enhanced primary care service provider. And by enhanced, I mean we go to our members where they are. 7% of our population in our program called One Care here in Massachusetts are homeless. So providing care for a population that's eligible and part of a program as large as Medicare and Medicaid means sometimes having to actually find those people where they are and where they live. We also participate in a program here in Massachusetts called Senior Care Options, which is a program that pre-existed the Affordable Care Act's creation. Oh, let me back up a second. One Care was created as a dual MMP program, Medicare Medicaid plan, out of the ACA. It was a part of that. It allows states to combine both Medicare and Medicaid into one program. One Care here in Massachusetts focuses on people under 65. So in order to be eligible for Medicare under the age of 65, you have to be disabled. And that's who we care for here in Massachusetts. 50% of the people in One Care for CCA have 4 or more chronic conditions. 75% have a behavioral health diagnosis. About 20% are addicted. We talk about the opioid crisis. I heard it over and over this morning. That's who One Care cares for, and that's who CCA. We will send case managers, and not only case managers, but care providers to those folks to bring care to where they are. It's really been a remarkable run for CCA here in Massachusetts. It was started by a physician here who was caring for folks who were severely disabled. It's real. I heard Secretary Norton, I gave you a promotion, Director Norton, talk about a solution to a unique need. Well, CCA is the solution here in Massachusetts, and the programs that we participate are. It is really a way for the federal government, the state government, and providers of care, and payers of care, and then finally the patients of care to really meet the 3 goals that I think all of us are most important, and I'll end with those 3 goals. First is to provide access to care to those who don't necessarily know how to or where to access health care. I've been in healthcare policy for a long time, and I still get confused when you get an explanation of benefits in the mail and it says this is not a bill. Like, well, if this is not a bill, then what is it? It could be something else. Imagine if you are a single mom or a disabled person who's just found housing, and now you're getting bills from somewhere that says it's not a bill, but it says that you owe money. So that's what these programs do, is provide access to a system that is very complicated indeed. The second is to provide quality care to those folks. You can provide as much care as you want, but if it's not working and if it's not providing access to quality care, then it's really not a system that you want to invest in. And then finally, the third goal of that is to provide savings and do it in a cost-efficient manner. So marrying those 2 programs, these 2 huge federal and state programs together, is my innovative solution to fixing healthcare. We're here to help you fix healthcare. And so I was encouraged by Director Norton's comments about working with stakeholders, because there are solutions out there to providing access to quality care for folks. We're not talking, in Massachusetts especially, here, the One Care program, we're not talking about Medicaid-eligible people who are able-bodied adults. These are severely disabled, mentally ill folks who need access to health care, who costs the most. And so this is an innovative solution. CCA, I welcome you to Massachusetts, and I encourage that the conversation in your states as you go back can think about some of the things that we've done up here.
Hi, my name's Dave Woodbancy. I'm with the American Kansas Society Cancer Action Network. It says that I'm a state director there. I was in the 90s, the state director in Hartford, Connecticut. I was our lobbyist there. I wish I was as young as I was in the 90s, but I am now with our Washington, D.C. office, and I get to work with our staff and volunteers in all 50 states. We are very fortunate that we have a staff lobbyist on the ground in all 50 states, and the Massachusetts folks may know Mark Heimovitz, who represents us here in the State House. But as Senator Moore mentioned, I'm going to talk from a cancer perspective, but I'm talking from a patient perspective, those that are battling any sort of serious illness or disease, because a lot of these topics that I'm going to bring up, and I'm just going to bring them up in bullet fashion to keep it brief, a lot of the topics are not just cancer related, but anyone, as I said, battling a serious disease. One of the things that's very frightening for us
is the prospect or the potential of bear counties, which has been mentioned earlier. That means, people don't have an insurance option in the marketplace and the exchanges. That is very much worrisome from our perspective. Of course, pre-existing conditions are huge for cancer patients and others with serious diseases. So the exclusion of pre-existing people it's not good for cancer patients or cancer survivors, to say the least. Medicaid expansion, it's been mentioned over and over how to reduce costs. One way to reduce costs with cancer is to get people into the system, get them screened, get cancer detected early when it's by far the cheapest to treat. And that's all cancers, and that's all serious diseases, not just cancer. That's the case for. We also, with traditional Medicaid, I'll just mention one fact that a lot of people aren't aware of, but in this country, 31%, almost 1/3 of all children with cancer are in the Medicaid program. 1/3 of all kids with cancer in this country are enrolled in Medicaid. So we obviously, traditional Medicaid is very important from a cancer perspective, and we are certainly advocating for the continuation of that program without budget hits that are a possibility the way things are looking right now. I'm also going to bring up something else that people may not love hearing, but opioids are very important to cancer patients. And I just plead with the legislators in this room. I've talked to some of you at our booth, and you seem to really understand the importance of a balance of policies. We understand in every state in this country there's a problem with opioids, and that needs to be addressed. But all we ask for is a balance of those policies so that cancer patients who legitimately need these meds to get through their day and night with some decent level of quality of life, that they can still access them. So, we've been advocating for prescription drug monitoring programs for years, and we also have been advocating interoperability. Border states need to be able to talk to each other. You don't hear a lot of people talking about that, but that's so important, especially for border towns. So we're going to continue to advocate to allow cancer patients to access the meds. The example that was used about getting a wisdom tooth out or a root canal and a 30-day supply, that is not necessary at all. But there are millions of cancer patients and cancer survivors who are not in active treatment who need opioids to get through their day or night, as I mentioned. So I implore you to continue that. And then one last thing I'll mention is something called palliative care. Nobody has mentioned that, but palliative care saves money, period. It's been proven over and over again, study after study. Palliative care saves money. And I applaud the 7 states. We have model legislation that we've been peddling for 4 years. We're now up to 20 states that have passed it. 7 states passed it this year. This is truly a bipartisan issue. The states that passed it: Nevada, Nebraska, Montana, Arkansas, Tennessee, Minnesota. So it's truly a bipartisan issue, and it saves money. Again, if we're looking for cost savings, it's not going to solve all the problems, but it certainly does, add to the savings. So I think with that, I will kick it back to Senator Moore, and hopefully we have some questions.
Okay, let's start with see if anyone has some questions of not only our 2 speakers up here, but Barbara Anthony's hung in there. She can answer any question. And Chiquita Brooks-LaSure is still with us. So if you have questions that you've just awakened and want to go back and ask that question of that speaker, we have a couple of folks who can do that. There's someone way in the back. Get a microphone to her. In the, what is it, that kind of a reddish-orange outfit. Who's there? Our microphone folks. Did they go to lunch? All right, great.
There are various reasons. Sometimes expense is one of the reasons, but there are a variety of reasons. That's just a statistic that has been shown to be truth. And so we just want people to understand that Medicaid from a kid, there's certain reasons why we have interest in the Medicaid program from a cancer perspective. That is certainly one of them, you know, pediatric cancer, and the fact that 31% of children with pediatric cancer in this country are enrolled in the Medicaid program. Yes, yeah.
Other questions? Dave?
Yes, Representative Dave Heaton from Iowa. So with Massachusetts and the Commonwealth Care Alliance, did Massachusetts carve out then their duals from their managed care approach and hand those duals to you to take care of exclusively? Or how does it work?
Like I said, Representative, there are two programs here in Massachusetts that cover duals. One primarily, or one exclusively for duals who are over 65, which is a program that has existed in Massachusetts for quite some time called Senior Care Options. They are covered either in the fee-for-service Medicare program at their choice or part of this managed care program. There are 6 plans. Commonwealth Care Alliance is one of 6 plans in Massachusetts who covers the over 65 population. In the under 65 population, where you actually have a single contract with both Medicare and Medicaid, Commonwealth Care Alliance is one of 2 plans here in Massachusetts, and they are carved into this program called OneCare. So there are still a number of duals in Massachusetts who aren't in either one of those 2 programs and are getting their Medicare coverage and Medicaid through 2 different programs. So it's carved out is probably a not a good term, but more like carved into these 2 programs.
So when a person turns 65 and they've been in one, do they remain in the same program or do they flip to another?
That's a really good question. OneCare has been around since I'm looking at my state guy here. It's been around since 2015. I don't know if we know what happens to the folks who turned 65 who are part of OneCare yet, because we haven't had enough history yet to know what will happen to that program. It's part of the ACA's Office of Duals. That's part of HHS and CMS. So those programs will expire actually in 2020. So I'll have to get back to you on what happens to those folks when they age out of OneCare.
Yes, in the second row there.
Good morning. My name is Ralph Palladino. I'm from New York City. I'm a member of AFSCME DC 37. I work at Bellevue Hospital, and I'm a patient at Bellevue Hospital as well since 1979. The thing about insurance is, insurance to me is not really access. Access is really having the facilities, the primary care doctors, the nurses, and the staffing that you need to be able to treat and take care of patients, and they need to be in communities where patients live. To me, that is access. We talk so much about insurance and cost. That's fine. But the thing is, what about the issue of access in that respect? I have to wait 4 and 5 months to get a primary care appointment for a routine annual visit. 4 or 5 months. Specialty clinics, sometimes I have to wait 2 or 3 and even 4 months in some of them, which is not right. Getting access in the phones and just try to get through to make appointments, bad, okay? The public health system in New York treats the patients like what was brought up before, I think Ms. Holland said about Medicaid and its relationship to private insurance. We treat the patients that the private hospitals are not treating and will not treat. So what about the issue of public health? What about the issue of expanding access in terms of doctors, places to go, and things like that? What is the relationship with insurance in that? And thank God for the Medicaid program, because Bellevue would have closed, and we're the oldest public hospital in the whole country.
I think Senator Moore might be more qualified to answer that question than either one of us.
We flipped the coin and you got
We're going to solve New York's problems. Yes, we had a question back here. Barbara, just before you ask that question, Barbara's going to take a shot at that.
You asked a lot of great questions. I'm just going to try to address the access issue and wait times and things of that nature, which I think, vary by state to state. In Boston, there's incredible wait times to see a new physician, even though I think we may have more doctors per head than lawyers per head, which is just an amazing thing to have in one state. But one of the things that we can do is what I mentioned earlier, is that there is legislation pending here in the state now that would expand the role of what I'll call medical paraprofessionals, such as nurse practitioners, expanding their levels of responsibility and their areas of expertise, expanding the roles of creating a new dental care, incredibly important. Insurance in dental care is a terrible situation, as we all know. Establishing a new type of dental professional called a dental therapist, somewhere between a hygienist and a hygienist and a dentist who can perform more things than a hygienist can. Podiatrist, optometrist, I mean, you name it. Every time we try to expand, we of course have to deal with entrenched interests, and I don't mean that in a derogatory way, but the usual, medical care society groups, everyone's trying to protect their own turf. The result is that we really do deny access to a lot of people. For example, one more thing. In this whole city of Boston, you won't find one limited care minute clinic in the whole city of Boston. And there's a long history of that, which I don't really need to go into. But it's an example of how, easy, accessible, affordable, transparent care is available in something like 54 cities and towns around the state, but in the largest city in our state, where we have about 1.5 million people a day either working or living, there's not one minute clinic in this state. So there are things that can be done. The government, state legislators, this is all state stuff, all local stuff, can do to have a positive impact in terms of access.
Thank you. I'm Travis from Oregon, and one thing we've been really working on in Oregon is high-cost prescription drug costs, and I was wondering what your thoughts are on how to increase access to those drugs.
There are various programs that some of the manufacturers have, but there is certainly an issue as these drugs get better and better and more targeted, and they're more successful treating diseases than the former class of drugs are. They're inherently more expensive, and we say that if people can't afford their drugs, it's not doing the patient any good if they can't afford their drugs. So we certainly advocate for people, for programs that allow people to be able to get these drugs, but it's not a perfect world, and sometimes people struggle to get the drugs that they need, and it's a national problem. It's a problem in every state, and there are folks out there with some creative solutions that have been talked about in various states. I have not seen a state yet where they have solved it, and unfortunately, the first state that does is going to be a hero because everyone else is going to do exactly what that state does. Put it that way.
There is a program later on this afternoon for the biotech group, and biologics would certainly be involved in that can be very expensive, but are also very important to certain limited individuals as well. Any last questions? Let me thank all of our panelists and Jane Norton from HHS.